welcome to the... Alright. So welcome to this webinar series on the cervical spine, sponsored by Philips Ultrasound. Today's topic, we're going to be looking at the cervical spine intradiscal injection. Historically, this procedure is being performed by CT or fluoroscopy. Today, we're going to show you some ways on how to identify the landmarks to be able to perform an intradiscal injection under ultrasound guidance in the cervical level. So here's Bob. Bob's back to help us out again. He's a fine specimen. Bob's a young, 35, healthy, fit, active person. And he's just off the MRI. We're going to pretend like he's got a C5-6 disc tear. So now we can use the ultrasound and we can find the right level. How to do that? We rely on those transverse processes. I like to start at the C7 level because there's only a posterior tubercle. There's no anterior one. So you can start there and slide up to C6 and then C5 and then go back and forth between C5, 6. And we actually want to shoot through the anterior part of the vertebral body. And we want to get to the level where we're on the disc and we can actually penetrate through that disc and see the intradiscal component. All right, so you notice we have Bob here lying on his side. We want gravity to help us out and do part of the work for us. The trachea and the esophagus, we want that to sort of shift more away from our needle pathway. And our window of needle trajectory is going to be posterior to the carotid artery. So this little pipe here I've put in is the common carotid. And then we have our nerve roots. So there's a window that's going to be basically in between anterior to our nerve roots, through that gap and to the disc. Now, if we imagine the sternocleidomastoid muscle and the platysma on top of that, so the sternocleido going from the clavicle to the mastoid process, we're shooting through that guy, then through the anterior scalene muscle, posterior to the common carotid, through the longus colli and or longus capitis, depending on your level. And we're watching out for those paraspinal arteries, the ascending cervical artery, inferior thyroid artery into the disc. We're shooting so that we're aiming for roughly 2 to 3 millimeters anterior of the uncinate process of the vertebra. We're going to look for that gritty pop sensation going through the disc of the annular fibrosis, and then a further centimeter in to the nucleus pulposus, give and that ease of pressure, and we can do our injection from there. Landmarks that we kind of need to know, there's a bunch of muscles that are helpful to identify, and so depending on what level you're going to be shooting for, what disc you're going for, is dependent on what anatomy is going to help you out. So I'm going to start with the EL18, and then we actually use the hockey stick, the new 26 megahertz hockey stick as well, and do a bit of a comparison. So let's take a look. So I like to start down at that C7 level that we talked about before. So sweeping up and down this lateral neck. So here's our C6, so I go down one, C7, here's our posterior transverse process with no anterior one, sliding up C6, big anterior, smaller posterior, and then C5, nice symmetrical U-shaped peaks. So that's how we count our levels. So if we want that C5, 6 one, here's C6, here's C5, and then we're in between the two. So let's come across to the midline, common carotid artery, strap muscles, omohyoid, sternohyoid, sternothyroid, our thyroid gland here, longus colli muscle there. If we're above the level of the C6, we're going to have some longus capitis in the picture too. Longus capitis, longus colli, anterior scalenes around the corner just here. So our needle pathway or trajectory is going to be posterior to internal jugular vein, common carotid, anterior to our nerve roots. So sliding up and down to identify our nerve roots coming out of that intertubercular groove. We've also got some of these arteries at risk. So using our color Doppler, help us to identify some of these arteries that are at risk too. So in relation to the disc, let's put our focus zone right down, drop our depth as well, down, probably punch 2 down. Now here's our beautiful shape of our vertebral body, so anterior vertebral body, and then up to the transverse process. And we're on the body, and if we slide down, this posterior shadowing will disappear, and we'll actually be able to penetrate down into the posterior part, into the disc. And this will kind of turn into this more hyperechoic rather than anechoic. And then we slide down, and that subtle fanning, we can see this ovoid shape is the disc. So we're in between the two levels of the vertebral bodies, and now we're punching through and we're looking into the intervertebral disc. We can turn into sagittal. So we've got the common carotid artery over the top, and then we have our vertebral bodies lined up in long, and then in between them we have our intervertebral discs, and they look a little bit like a knee meniscus when you're doing a knee scan. There are a few other things to be aware of too. Phrenic nerve and some other of the arteries, and we'll use our hockey stick. So we'll use our 26 megahertz hockey stick to identify those smaller structures with higher frequency. And I'm putting on the dermal setting, which I've come to love, and I'm going to use trapezoid, even though that's a bit of a no-no, but I love the sector that we can see and identify so much of the anatomy in one shot. Zoom in, change to high res again. Jumping over the top of our anterior scan is going to be our phrenic nerve. So here's our phrenic nerve just here. And if we suss out our needle pathway, let's do a surveillance scan. So no surprises are going to sneak up on us before we pop a needle in there. Let's go and find our level. So here's our C7, come up, C6, C5, between the two. C5-6 disc is going to be down here. So we're sussing out in here. So this is our longus colli. And we know that on the surface of our longus colli muscle lives our parasympathetic ganglion. More inferior to this level though, this is quite a safe level. So C5 nerve root here. Good, so we've got it situated there. And I'm really happy that this would be my needle trajectory planning. So I'm going to come through the sternocleidomastoid, over the top of C5 nerve root. I'm going to go posterior to the phrenic nerve, through that anterior scalene muscle, into the longus colli muscle, and then down into the disc. If you notice up the top too, we've got a little artery, that's part of the thyrocervical trunk. A vertebral artery is tucked away nicely down here. Inferior thyroid artery will be posterior to the common carotid, and that is a clear pathway with no arterial or neurovascular bundles in the way of my needle.